This meeting is now being recorded. Good day and welcome to Partners in Care, Module 3, Practice Guidance for Mental Health Professionals in Leveraging Community-Based Partners. As you will notice, all participants have been muted. If you have a question to ask, please submit your questions in the Q&A pane, the icon of which can be located on the bottom of your Zoom window. Your questions will be answered after the presentation. If you have any technical issues, please send a chat to all panelists and hosts, the directions of which can be found in the chat window. Thank you for joining today, and please welcome Dr. C, the Medical Director of Fountain House.
Hello, everyone. Welcome to this third module in our Partners in Care training. I'm really pleased to be able to represent Fountain House today, as well as the New York University School of Medicine. And I would like to begin by welcoming our guest speaker for today. This is Dr. Ralph Aquila. He really led the foundation of this training to help us to understand how Clubhouses, as an example of community supports, could really partner with psychiatric providers. Dr. Aquila is a psychiatrist who for 30 years was the medical director of Fountain House and really developed Fountain House's clinical partnerships around the community. To make sure that Fountain House members not only could pursue their own recovery within the Clubhouse community, but also get quality psychiatric care. And now he has turned the job over to me in this past year, and it's been an extreme privilege. He said he was retiring, but actually he's in an equally busy job as the medical director of Horizon House in Pennsylvania. We're really happy that he has brought us this training and has been able to join us today to introduce the topic. Thanks, Dr. Aquila.
Dr. C, you're too kind. This initiative is the work of so many, and I'll get into that, but I want to start by saying hello, friends, hello, colleagues. And by the way, colleagues, you all know what that means, right? That's members and staff, because that's part of our core values in the Clubhouse world, that we all work together. And what you will hear today, which is the culmination of almost 3 years of a collaboration between members, staff, distinguished thought leaders from literally around the world, that what is possible is recovery, and also to provide what we called a couple of years ago, healthier, longer lives for people who are struggling with serious mental illness. I want to give a special thanks to Dr. Javed and the World Psychiatric Association for their collaboration, for their actually supporting and hosting this particular modules of recovery, which will be available, from what I understand, on their website moving forward in the near future. So again, a big thank you to Dr. Javed, to the World Psychiatric Association. But what I really want to underscore on this special occasion, the third module of Partners in Care, is really how the 20,000 plus members that have gone through the green doors of 47th Street and the many others that have gone through the Clubhouse doors, and the countless many who every day wake up with and are struggling with serious mental illness, can recover and know that there is hope and there are possibilities. So I'm going to ask you to indulge me to go down memory lane and kind of describe to you what it was like to kind of form this partnership. What we've learned, and what I knew back in 1990, which was very, very little, was that Fountain House already had understood the importance of housing, nutrition, employment, education, transportation, and socialization. They understood that loneliness would make anybody's life challenging, but if you had a serious and persistent mental illness, even worse. And what they're called today, the buzz phrase is social determinants of health. But the Clubhouse world had understood that way before so many others did. Again, when I finished my training, the concept of recovery from serious mental illness was pretty nuanced. Mainstream psychiatry had not yet embraced it. The state of New York, where I practiced for so many years, had not formally instituted it until 1994. And again, the Fountain House model, the Clubhouse model has been around since 1948. So clearly, this model has clearly been at the head of the line, has really been the avant-garde. The other key thing that we discovered back then was that people with serious mental illness were dying prematurely. And it wasn't really clear or understood. And there wasn't much data until the late 90s that showed the excess mortality. And we were fortunate to partner with the World Health Organization and others to be able to kind of put some numbers on it. And what we discovered was that people with serious mental illness were dying 15 to 25 years sooner than the general population. So what we understood at the time was a call to arms, was a call that we had to figure out how can we make improvements on the excess mortality side. How do we partner with a wonderful model like the Clubhouse model to get us, help people to really advance and move forward with their recovery? So what I understood and what my colleagues understood was that if we were to partner with a community like Fountain House that basically, as I said, had delivered or was focusing on all those social determinants of health, we could then fine-tune some of the key issues that would hold people back. And what you will hear in the presentation, eloquently described by, again, members and staff, including Dr. C, that if we work together, if we are able to really bring all the pieces together, we can make significant improvements. You will hear specifically about the Rehab Alliance. And what I want to underscore is that it's always been the member who is the captain of their ship. It is the member who drives the recovery process. That said, social practitioners, when I was the psychiatrist at the time, we would certainly be helpful. We would certainly be involved in trying to eliminate any of the barriers that could hold people back from moving forward with their lives. But again, the real key was focusing on life goals. And what Fountain House taught me way back when was that it was pretty simple what people wanted, regardless of their background, regardless of where they were in their recovery journey. They wanted a nice place to live, something meaningful to do with their lives, and a network of friends and family. Pretty much with everybody on this call, everybody that's around the world would love for themselves and for their loved ones. Nothing too complicated here. So again, the understanding that people can get better, the understanding that there are complications to having a serious mental illness when it comes to medical comorbidities. Not always clear why. Is it genetics? Is it poverty? Is it the medications that are oftentimes used in treating people with serious mental illness? It's probably all of the above. So again, the notion of delivering, and there will be a wonderful slide that really underscores the community system of care. And you will see how when you bring integrated care, which again has become another buzz phrase, right? Bringing medical and behavioral health together. To me, that's not sufficient. What's really required is the community, or a model similar to Fountain House, which can deliver community and address the social determinants of health. So I'm going to leave it there. I'm going to turn it back to Dr. C. I'm going to thank you all again for all the hard work you do, and really thank you, and looking forward to this presentation, and see you later in question and answer.
Thank you, Dr. Aquila, and thank you for your long decades of leadership in bringing the Clubhouse community to the fore and making psychiatry an important part of the picture for integrated care with community-based supports. I'm going to start by introducing our panel for today. Really pleased to be presenting first with three members of Fountain House who have in their own right developed real careers around promoting the health of people with serious mental illness. One is Diona Petty, who is a fairly new member of Fountain House, but has already established herself as a tech genius who fixes everything in the house and a really great tour guide as well. Craig Bayer, you've seen in our previous trainings. He is a member of Fountain House and also the editor and founder of the international Roar Journal that publishes poetry and other works around the world. And Cyrus Napolitano, who is a member of Fountain House again, but the co-director of the Clubhouse New York Coalition as well. Also with us today are Kevin Rice, who's the Director of Research at Fountain House, Dr. Eric Atchis, who was our guest speaker in the last module. He is an associate professor at Michigan State University, as well as the Behavioral Health Medical Director for Network 180 in Michigan. And on our panel, we have Dr. Francesca Pernice, who's the associate professor in educational psychology at Wayne State University in Michigan. And Kinga Jędrzejczyk. She has organized and coordinated this training and gives us so much, but does mostly background work to keep us all in coordination in this training. So thank you to our panel. And we will speak in turn and then have a Q&A session at the end of this presentation. So we can go to the slides for today now. I'd like to emphasize, like Dr. Aquila said, that Fountain House is doing this training in collaboration with the World Psychiatric Association and an international advisory board with many psychiatrists and experts in the field, including our colleagues from Wayne State College of Education and Magnolia Clubhouse in Ohio. And this training, on the next slide, we talk about how we are primarily focused on how psychiatrists and community-based supports like Clubhouses can work together in the service of the recovery of people with serious mental illnesses to provide integrated care that not only integrates the physical and mental health aspects, but also a person's participation in the community, and like Dr. Aquila mentioned, how they live, work, and play, which, as we know, Freud said were the key features of human life and what is important to us. If you were with us for the last two modules, the first module talked a lot about integrated care, the landscape of integrated care in the US and around the world, and what the importance of community-based supports is to that equation. Our second module talked a lot about community-based supports and used Clubhouse as an example of how this works, how we can use social practice and intentionally designed therapeutic community to support people in their recovery. And in the next slide, is the title slide, I'm going to introduce Module 3, which provides practical guidance as well for mental health professionals in leveraging community partners. So this is the nuts and bolts of how, as a community psychiatrist, nurse, social worker, you can work with a Clubhouse to help your patients to recover. On the next slide, I'm just going to give the overview for today, which is we're going to talk first about the historical context of the idea of recovery. You know, I didn't actually train that long ago. I think it was, I finished my residency 16 years ago. But even at that time, I think that the idea of recovery was new. The idea that people with schizophrenia weren't just going to, live lives that without purpose, with constant symptoms, with heavy medication. That idea was fairly new, that people could actually, with schizophrenia, finish school, work, have families, have children, pursue their dreams. That was fairly new. And the idea that people with schizophrenia could come off medication altogether, that was absolutely new at that time, I feel. But actually, it wasn't new, because Fountain House and other clubhouses had been aware of this and working on it for decades, even before I trained. And I think what we've seen in the last few decades is that these ideas have come to the fore. They've really come to fruition. And so we're going to talk about this recovery theory, this conversation that has been present recently. And our Fountain House members are going to talk about that to help make it real, what recovery really is. We're going to talk about how recovery has evolved in healthcare partnerships and also evolved healthcare partnerships, and what that means for us as community psychiatrists as well. And we're going to talk a little bit about the unique care dynamics and practices that can be implemented when you are partnering specifically with a community-based provider, including a clubhouse. So dialing it down, I'm going to talk, mention our learning objectives on the next slide. So we're going to describe the state of recovery theory. We're going to discuss the partnership dynamics of community-based service providers, clinicians, and other mental health professionals, as I said. We're going to talk about practical clinical strategies to enhance care in collaboration with community providers. And we're going to identify and talk about the specific roles and responsibilities within an integrated care model that includes community. Next slide. All right, so I mentioned, the growth of recovery in the last couple of decades. I think we've talked about recovery in a lot of different ways, and there's been a tension between different biological, psychological, and social foundations, theories of recovery. We don't, we don't really have a consensus definition, although we're going to present one that we have seen published and really feel describes our thinking around recovery. But there are a lot of different paradigms. So, for example, a subjective versus objective idea of recovery. If someone feels that they are recovered, are they recovered? Or is it more dependent on how people are seeing that person? If someone feels that they're living the life that they want to live, but others are not quite so sure, is that valid? I have, for instance, one patient I care quite deeply about who has chosen to live in the streets. His main interest is skateboarding. He prefers to sleep in the skate park, and to him, this is the life that he lives. His mother would disagree that this is an idea of recovery. I, as a psychiatrist, feel very concerned when the weather gets cold of how this affects his health. But is it up to me, or is it up to that person to determine what is recovery and what is right for him? So the subjective and objective definitions, again, can sometimes differ. Again, personal versus clinical. Are we talking, when we talk about recovery, are we talking about someone's desire, for example, to have a baby? Sometimes people around that person might say, you don't have a home, or you don't have a sustained source of income. Is that a good idea? But that may be that person's personal goal. Clinically, I might say reducing the risk of heart disease and diabetes is our goal, but that might not be something that the person identifies with. And how do we meet then in the middle, or in some definition of recovery that is both healthy and really actualizes that person's real values and needs? Is it outcome or process oriented? Are we looking for the end goal of this person wanted to have a baby and they're going to have a baby, and that baby is the recovery goal? Or are we talking about the process that getting housing, putting that person's life together, getting a regular source of income, all of the things that they do towards that goal that they have in mind is the recovery? And so there are a lot of ideas, thoughts, controversies around this idea of recovery. And what we, I think, sometimes neglect to think about is that really recovery might be about connectedness to other people, hope, optimism, identity, what someone considers to be the meaning of life, which is very different for different people, and their sense of empowerment, their sense of the ability to make decisions for themselves. I know that even my talking about the idea of pregnancy for people who have schizophrenia might, I think, create many feelings in people listening to this presentation. And, rightfully, pregnancy is one of those things. There is many, implications, right? But when we talk about the meaning of life and someone's actualization, how far are we willing to go as a field to help someone actualize their actual dreams and goals? And that's a very important question for us as psychiatrists. And it's an important question in terms of how we support people and what are the end goals of our profession. If we go to the next slide, I'm going to really dial down into two main definitions of recovery that have gained prominence and that we need to sort out here. And so the first is a service-based definition, right? This is from the perspective of me as a psychiatrist working with a patient. So for me, the things that I have been taught to ask about and consider important might be things like mood. Is someone still feeling depressed or irritable? Hallucinations, are they disturbed by voices? Anxiety and paranoia, and things like sleep, appetite, self-care, hygiene, all of those things might be what I am thinking about as being important. Whether someone's coming to treatment regularly, that's an idea of recovery I might have, like their connectedness to treatment, their attendance at therapy, whether they're taking their medication. That is often like the first thing in the mind of a psychiatrist. Are you taking your medication, right? So we look at symptoms, we look at functioning. Is someone working? Or do they have a place to live? Those are our definitions, service-based definitions of recovery. But for the user, for the person who has schizophrenia, bipolar disorder, major depression, the goals might be very different. They could be, did I get into the art history program that I wanted to get into? Am I able to go to eat at my favorite restaurant once a month? Can I date and meet the person, a partner that I hope to be with? Can I move to California? Because that is my recovery goal. Those are user-based definitions of recovery that are very personal and that a psychiatrist could not know about without really getting to know a person well. And these are subjective definitions of recovery that are nonlinear. So for me as a psychiatrist, it's like, okay, I want the voices to go down and down and down until they're minimal. But for the user, really, it might be like, this month I want to pursue art history, but next month it's more important for me that my dating life is not nowhere to be found. So I think though there's a tension between psychiatry and the person served in what is recovery. The next slide, please. I think as a field, we have come from a place of paternalism where we really have told and made decisions for patients, told them what to do, come from a place where people lived in asylums and were kept away from society. Over the last almost 100 years, we've come during this time to a place where we really, as Dr. Aquila said, look at the patient as the captain of their recovery and the captain of their ship. And so these are self-directed models we're looking at today, where people, through collaboration with their partners, with their clinical providers and their community partners that can include friends, family, their place of work, their housing, and sometimes a clubhouse or other community partner, that they use these services to move towards recovery. And often we find, like Dr. Aquila said, that the most important thing is not so much even the medication or the voices or any of that. What is important is the social cultural drivers of health. Whether that person lives in the place they want to live in, has the food to eat that they want to eat and that they feel secure they will have tomorrow to eat, whether they have clothing, a job, someone to hang out with on Friday night. Those are the things that are really important to a person and determine whether they take care of their health and how they take care of their health, which is in the end what is really important in terms of recovery. Next slide, please. So I've talked from the psychiatrist perspective about what recovery is, but I can't make it real for you the way my colleagues here at Fountain House can. And so I'm really pleased to bring Diona and Craig here to talk about their own journeys and what recovery really means to them so that folks can understand about it.
Thank you, Dr. C. I'm Cyrus. Craig will be following up a little while, a short while. But I want to thank all of you who are here from all around the world. I saw people from Ghana, Kenya, the Philippines, Taiwan, Europe, the US. And that's fantastic that we're having such a wide-reaching audience. And many of you have participated in the full training so far to date. And this is exactly what we want to accomplish, is to really spread the word about our community system of care, our partnerships, our relationships, how we engage people with serious mental illness. And today, Dr. C was talking about recovery. So I'm going to spend a little bit of time chatting with Diona after I've kind of set the framework for talking about recovery and what that means. And of course, you have the definition right there in front of you, that it's a self-directed process through which individuals with histories of serious mental illness improve their health and wellness within their communities, developing opportunities and identities not limited by their illness. Now that's a mouthful to say when you're talking about recovery, but what does that mean in practical terms? So many of you are well aware of the challenges of treating serious mental illness, and we're talking about schizophrenia, bipolar, major depression, and to a lesser extent, schizoaffective disorder. And it's particularly hard because in most communities around the world, there are very little services and supports available. So what do you do? And hopefully these modules will help you figure out what to do in your own community, in your own backyard, to really provide the services and supports for people with serious mental illness. Because what we are demonstrating, I hope, is that recovery is not only possible, but it is expected, particularly in our clubhouses, particularly at Fountain House. And what do we mean by that? Well, if you have the necessary services and supports, members are empowered to live their own lives. They're self-directed in their own recovery, meaning that they're the ones who make the ultimate decisions as to what kind of treatment options they want to go. And as Dr. C was saying, she has a patient, a member of Fountain House, who prefers to live on the street, who likes to do skateboarding, who has his own ideas of what his life should have purpose and meaning. You have to respect that. You may not agree with it, and your role as a professional is to kind of help the member understand the possible consequences to these choices. But at the end of the day, you really need to let go of the control that in the past many psychiatrists had over their patients' lives, and allow the individual to make those choices. Because if it's not voluntary, it really imposes upon the individual that they have no options, that they're being told what they need to do in their lives. We're talking about recovery through the various opportunities that Fountain House and other clubhouses provide. We're going to talk a little bit later on about trust. And we're talking about building self-esteem and self-efficacy here. So members are integral to this process, and it's ongoing and it's always changing. And you learn from working with each other, with a psychiatrist, a therapist, the social practitioner at the clubhouse, other members, people in administration. If you are on the board of directors, you learn from them. So it's about active engagement, because you're going from somebody who is a passive recipient of services and supports to somebody who is an active participant in an intentional community, meaning that everything we do in the community should have a specific purpose in mind. It's not about make work or just gathering together for socialization, even though that's an important part of recovery, is learning how to socialize and rebuilding your lives and your relationships. And, you know, I was giving a tour a number of years ago to a group of folks. I don't remember if they were funders or not. It doesn't really matter. And one of the women in the group asked me, well, what do members want? And I said, well, what do you think members want? And she gave me this very rote answer, and it was kind of, didn't really get to the heart. And I said, look, people with serious mental illness want the same things as everybody else in society, except we just need a little help. We need those additional services and supports to get there. And Diona's story, I think, is going to demonstrate to you how this is possible. So why don't we, one other thing I want to say, and Diona's story is really critical to this, is about creating your own identity, separate from the diagnosis, separate from the illness. That's really critical because, for example, when I was speaking at an event in India a number of years ago, I gave what is my man in the mirror speech. And I'm up there in a suit and tie, I'm clean shaven, suffering from serious jet lag, so I was a little tired. But I started talking about the work that I do and my relationships. I didn't mention my diagnosis at all because it wasn't important to the conversation. I don't go around saying I have this diagnosis or that diagnosis, which already puts you in a kind of weird position with other people you meet and work with in life. Do people go around saying I am cancer, I am Alzheimer's? No, why would you expect that of somebody with schizophrenia or bipolar? So let me bring in Diona. Diona and I are just getting to know each other. We spent some time yesterday chatting about life and her life before Fountain House and her life during Fountain House and what she sees as her future. So Diona, thank you for being here with us today. I want to say that I'm very impressed by what I have seen and observed of your participation in Fountain House. You've only been a member now since November of 2020, correct?
Yeah.
So before you came to Fountain House, you were involved. Can you tell us a little bit about what was going on before November 2020? You were in a program, you had been working, I think you lost your job. Can you tell us a little bit about that story?
Yeah, I was going to a clinical program and I was also working, but then the pandemic happened and I lost my job and my program went virtual, so I didn't have a physical place to escape to, and I didn't feel like I was getting the kind of support that I needed at the time. And I noticed that my symptoms were getting a bit out of my control.
Right.
And I felt like it was getting to the point where I may have needed a hospital stay, something that I had avoided for over a decade.
Right.
So I I felt like I was kind of moving backwards. So after I eventually I stopped showing up to that program, and my counselor from that program, she decided, she recommended that I join Fountain House. It was something I'd been talking about for about 2 years at the time, but since I was working and then before that going to school, I didn't really have time to pursue it. So I I applied and I got accepted. But since it was during the quarantine, I had to join virtually, and it was very difficult because even by that time, I felt like I had, Zoom fatigue, and I I wasn't very comfortable at first because I was meeting people basically on a computer. Um, and during the first, I would say 3 months, I really I felt like I wanted to stop showing up, but I wanted to push through because I didn't want to isolate. Um, I don't like to isolate, and I mean I was forced to isolate like everyone else during the quarantine, but I my worker at Fountain House, um, she really wanted me to show up, so I would call her and ask like how can I be more involved, or how can I be more social, and uh, she gave me a lot of tips. When I didn't show up, she would call me. Um, and over time, I started to feel more comfortable with myself and the other members and staff at Fountain House. Um, and I did not go to the hospital, so that was a plus. And eventually, the house opened back up, and I was attending 5 days a week because I like being around people. I like having something to do. And at Fountain House, I felt like everyone there, I felt cared about and needed, which I feel is essential to recovery. And most importantly, uh, to me at least, I felt safe and like I had a purpose. So, uh, like I said, I showed up 5 days a week, 9 to 5. I still do that,
Wow,
and I feel like,
that's
and
impressive.
sometimes on the weekends, yeah, and I feel like Fountain House has made me made me feel like I have a future. Uh, they see my strengths and not my weaknesses. Um, and it helped me also more see my strengths and also not focus so much on my symptoms. And I feel like I can reach goals that I felt for a long time were impossible. um, and making progress that wasn't just whether I feel safe or not today, like real progress to me. And I feel like it helped build my confidence and my self-worth again after being eroded by the pandemic and losing my job. And I try to be very involved with the clubhouse. I help out in the with IT. Um,
Right?
I'm on the programming. committee and the steering committee and the advocacy. I tried to try out every group just to see if it was something I was interested in, and I settled on a lot of different meetings just to keep myself busy and occupied. And also, I planning to go back to college in the fall. It's something I didn't think would happen because the last time was a disaster. But and it also at the time led to my first trip to the hospital. But yeah, I plan to apply to several schools for. I want to study web design or web development, and hopefully, pursue a job in either of those fields.
Fiona, your story is so powerful and has such a tremendous impact. I don't think you realize how well you've done today, because I didn't have to prompt you for anything. I just want to ask you a question. Now, the program you were in prior to coming to Fountain House, when we were chatting yesterday, you were saying to me, and correct me if my memory doesn't serve me properly, is that they were telling you how you were doing in the sense of how you were feeling, but that's not what you were really feeling. They were focused more on your symptoms and your illness and your diagnosis, rather than focusing on Diona as a person who has self-worth, who is able to do things like IT technical stuff a lot of people are afraid of, and it scares them off because, it's technology and a lot of people aren't comfortable with technology, but you took that on. Can you talk a little bit about that experience and what the difference is between that, and a little bit about how that's changed by being at Fountain House? You've already said it, but I want to look at it from another angle, if you can explain that for me.
Sure. At my previous program, I felt like I was doing fine. There was a pandemic, so I felt like I was doing the best that I could, and I was feeling a little down like everyone else. But it just felt like people were telling me that you really depressed, you need a lot of reassurance, and things that I didn't feel were very helpful at the time. It was kind of making me feel like I was regressing. But I felt like I was doing as the best that I could with what I had during that time. But coming here, I don't hear you look depressed or stuff like that. It's I hear you're very talented. You're very kind. Things that I find very helpful to my self-esteem, which has been low at times.
So you're getting a lot of positive affirmation, and not somebody telling you that you're depressed or you're not doing too well and things like that.
Yeah.
And yesterday, I'm sorry, and yesterday you were talking about, you said that you come to the Clubhouse Monday through Friday, and sometimes on evening weekend events, and you're there from 9 to 5, that you're walking through Fountain House you were saying that I'm saying hi to everybody I meet, even if I don't know them. That's very important. Why do you think that's necessary for your recovery to do that?
Well, I feel like I know how it is. I knew how it was to be new and sort of scared of a new place and new people. So I want people to feel comfortable here, and I feel like I get a lot out of the program, and I want other people to stay and get whatever it is they want out of here. And also I just like talking to people. I I like socializing. I don't like isolating, and yeah, I like people.
Okay, well, thank you so much, Deanna, for your sharing your story with us, and that you have hope for a better life tomorrow. I think that's fantastic. So I'm going to turn it back over to you, Dr. C.
Thank you. Thank you, Cyrus. And sorry that I mixed up that it was you and not Craig that would be presenting. I would say that, you know, one of the joys of working in Fountain House is that everyone you meet inside the clubhouse, it's actually pretty hard to tell who is a member and who is a staff, because everyone has a purpose and something that they bring to the table that's amazing. And I think, you know, I actually don't even know really what are some of the more challenging things sometimes that Craig or Deanna or that Cyrus or sorry, Deanna experience, because honestly, I talk to Deanna when I need a computer fixed, or when we have an emergency and someone needs to give a tour to a new guest. And I talk to Cyrus because he helps me figure out these presentations and make sure that we spread the word about Fountain House to other people. And so I think that's recovery, when we can all live in a community where people don't focus on our deficits, mine included, but instead on what we can bring to the table and how we can all help each other through our own personal journeys in recovery as well. So thank you again. I think that Deanna, you really made real for us what it means to recover, and you know, what the journey looks like. Thank you very much, and thank you, Cyrus, as always. If we can move to the next slide, then I'm going to move from talking about recovery then into the community partnerships between clubhouses and clinicians. And so in the previous two presentations, we showed this graphic of how our field has talked about integrating physical and mental health care for a long time, because for too long, psychiatrists thought about things only from the brain point of view, depression, voices, and so forth, and not paying attention to the cardiometabolic risk of people with serious mental illness. And for a long time, I think people who worked in primary care and other specialties would look at the physical body and say, oh, you have a depression or some mental health issue, you know, go talk to a psychiatrist, it's not for me. And we've tried to bring those things together. But what is important is how whether you have access to food and clothing affects whether you are depressed, and affects your heart and diabetes risk. And whether you have a job might determine you know, how you take care of yourself, and vice versa. So thinking about the importance of the social cultural drivers of health and how community-based organizations really support these socio-cultural drivers of health, bringing that whole picture together has been what we've been talking about. And we've used Clubhouse as an example of community-based supports that create an environment where people can find recovery. Today, we're going to talk more about how Clubhouse staff, in doing their practice of social practice, where they look at engaging members in useful work, relationships, and helping them to transition to roles in the larger community, how they also can help to broker trusting relationships with clinical providers in the community so that a person can recover in a whole way. So not only reduce disruptive symptoms that affect their ability to function and recover, but also pursue all of the features of recovery that they're after. Next slide, please. So I have two slides here. One is about what Clubhouse can do for providers, and the next is about what providers can do for Clubhouse, because it's a two-way relationship, and I want to emphasize that. Kevin Rice is going to talk to you at length with the help of Craig Bayer about the Rehabilitation Alliance, how really Clubhouses, as a network of people that stand behind Cyrus or Giona or Craig, how this community of people ensures that the person is getting good care and brokers trust with the clinician who may have been vetted by and is trusted by the community. I, as a psychiatrist working with the Clubhouse and specifically in my role at Fountain House, I find it absolutely enriching that when I meet with a Fountain House member, I'm not just asking my typical 10 questions. How's your mood? Are you hearing voices? Are you sleeping? Are you eating? What's your energy level like? Are you taking your medication, et cetera, et cetera. But I can also say, like, oh, Susan told me that you did really well in karaoke the other day. What was that experience like for you? And, oh, I saw you in the comedy show the other day. You were hilarious. That was amazing. Or I heard that you've done better with picking up your room recently, and that you did laundry for the first time. Whatever it is in that person's life that they're achieving or struggling with, I have a 360 view because I have the Clubhouse helping me to understand the full range of a person's identity, meaning, purpose, and functioning. So that is really enriching as a psychiatrist, because I'm not then just making a decision on to increase the Haldol based on how much voices there are, but what does the Haldol mean in terms of helping that person to participate in the research project that Fountain House is doing, right? As a provider too, sometimes as a primary care provider, you might see someone every 3 months to every year. As a psychiatrist, usually it's about once a month, every 3 months. If I say you need to eat healthier and you need to, make sure that you don't have a heart attack, I can say that at one session. But the true meaning and opportunity comes when we meet together with a person's social practitioner and with the person and say, like, hey, the diabetes is really getting worse. The A1C is going up. It's creeping up to 10. We really need to think about the implications of this for longevity, for the risk of dialysis. And so what can we do together? And the person says, well, I will, try to go to the gym more and eat more vegetables. We can say that in a 15-minute, 30-minute session. But when that person eats every day at Fountain House and shows up at the wellness unit where there's a gym every day, then there's the opportunity to make change on a daily basis, to really say, hey, have you gone to the gym today? Hey, that looks healthy what you're eating. Looks good, And so that daily growth, monitoring, continuity of care is possible through a community support like a Clubhouse. And that helps to engage the person in this momentum that develops towards full recovery. When you have a Clubhouse or another community provider that is set up to support healthy habits, to provide healthy foods, to provide opportunities for exercise, to provide a walk in the community, that helps people to get their heart rate up, I think that is when you start to see healthy changes be possible. So all of that, conspires to create hope for change in our members and for the staff working with them. Importantly, when you are working with a member of a Clubhouse who is supported by a community, there is an enhancement of the opportunity for shared decision-making, so that it's not just me saying, Haldol should go from 5 to 10. It's really a conversation between me and the member about what is important to them, how the community sees them, and what each decision could implicate for recovery. And then I'm not making the decision by myself. the person is making the decision with my help, and the community is supporting that decision making. So that's really important, how community can help shared decision making. And ultimately, I can use less Haldol because I know that there are folks who have this person's back, that if I use too little medication and that person has a crisis or gets sick during the month, there are so many people there to catch that person, to bring it to my attention so that I can use less medication. And that is huge, I think, in terms of the implications for cardiometabolic risk and long-term side effects. I think our ability to help people recover with the least medication possible and with the most empowerment possible is huge when we work with Clubhouse. So that's all of the things Clubhouse can do for providers, which I, as a provider, have found to be amazing. So the next slide is really about why Clubhouses and other community-based interventions need providers. Well, ultimately, it's important as a referral base too. Many of our referrals come from psychiatric providers in the community. And so people hear about Fountain House and they know that patients need more than just medication or even therapy for recovery. And so they refer folks and are able to take advantage. Spreading the word about Clubhouses throughout the community is really important too. Obviously, I think Clubhouses need to partner with providers because people need good preventive care, acute and long-term care. They need, members need somebody to look after their diabetes, their high blood pressure, their depression, sometimes their suicidal ideation, and having providers that a Clubhouse or a community provider trusts in the community is so important for that reason. Providers, importantly, can provide corrective experiences of healthcare in the establishment. Too many people experience serious mental illness in part because of trauma in their childhood and throughout sometimes. And we know through the Adverse Childhood Experiences study that trauma can have lasting implications for mental and physical health and can really affect health outcomes. And it affects people's ability to trust a healthcare provider and work with a healthcare provider towards their own recovery. I think when a Clubhouse vets and supports the work of a provider, it can be huge in terms of the member being able to trust that provider. But what the provider's responsibility too is to not be the same traumatizing picture of, one flew over the cuckoo's nest that patients fear, but instead to really be that person who does shared decision making in the service of a person's recovery goals. That's what providers can do for Clubhouse. The next slide talks about how Clubhouses and providers change over time because of this collaboration. I have found that for a Clubhouse, when they're involved with an outside provider, one thing that happens is that the Clubhouse then needs to, participate in more systematic monitoring. The psychiatric provider from an outside hospital might say, hey, what is actually happening with this person? Can you give me information on a weekly basis or a monthly basis? And that behooves the Clubhouse then to keep, good records, to remember to email that provider, to remember to attend the appointments with the member so that that we support that kind of care. I think Fountain House has developed a care coordination department, which is separately funded, that also supports this work because this has been such an important need. I think it brings to the Clubhouse too all kinds of confidentiality questions that may not have been there before. When you're working with an outside provider, you have to make sure that you know that the person wants to share certain pieces of information with their outside provider or with someone from another unit or with their housing. And I think that what we've seen that providers bring to Clubhouse is a desire for evidence of effectiveness of what we do as Clubhouses and for data-driven care. And so showing that we reduce hospitalizations, homelessness, incarcerations, all of those things has become more and more important for Clubhouses because of partnerships with providers. On the other hand, Clubhouses impact providers too. I think the advocacy that Clubhouses provide ensures that psychiatrists are more often going to be thinking about recovery goals. And I've seen too that the involvement of a Clubhouse means that people stay with a provider for a longer period of time. And this is because the person is often well for a longer period of time, has a community, and has continued communication with the provider because of this longitudinal relationship. When you're a member of a Clubhouse, you're a member for life. And the Clubhouse remembers who was your provider before and will support your relationship with that provider. So that's really big. As a psychiatrist, I think also my ability to care for people who have been marginalized, people who are homeless or formerly incarcerated, increases because the Clubhouse provides a range of sociocultural supports and real advocacy for that person. Helps them get off the street, helps them to stay out of prison, helps them to get food and clothing, helps them to get a job. And those are the things that help me to maintain contact with a person and maintain the efficacy of treatment in service of that person's recovery. So that's the nuts and bolts of what I think are real, what we think are real bonuses of the partnerships between Clubhouse and providers. Next slide. That's a picture of Dr. Aquila outside the doors of Fountain House. And we show him here because he really pioneered this Clubhouse community system of care. Importantly, clinical care is not provided inside the Clubhouse. The Clubhouse is community. It's a place where people come to work, socialize, relax, eat, work out. Clinical care happens outside. It's not part of the Clubhouse model per se. But right now, for instance, I work at a clinic just down the street from Fountain House where people will come for appointments. So the care exists outside. And the team that comprises this Clubhouse community system of care includes the member, their social practitioner within the Clubhouse, possibly also their housing case manager or care coordinator. But the external people are myself as a psychiatrist and primary care and other specialists. Where we work right now is the Ryan Chelsea Clinton Center. And so bringing this team together is the responsibility of the Clubhouse community system of care. Making sure that there's communication between all these partners ensures that the member is getting the best possible care. Next slide. It's been a long history. Fountain House, as we've said before, is almost 75 years old now. And so we've been creating this Clubhouse community system of care for a long time. And it's been through a few iterations. I think initially there was a partnership with a large hospital, Mount Sinai Hospitals, and many trainees were involved in the care here. The one seminal sort of a step in this history was when Dr. Aquila helped, found the Sidney R. Bear Jr. Center. Sidney Bear was someone with schizophrenia who really contributed a lot to the development of our field and to advocacy for members, and supported, his foundation supported the development of a clinic that specifically served Fountain House members with both primary and psychiatric care. And it was one of the first integrated health home models in the US for people living with serious mental illness. Over time, Fountain House has recognized too that that clinic provides very good care. But we've also diversified the different partnerships we have so that we have members having a real choice of quality providers that are vetted by the Clubhouse community, that the Clubhouse has said, like, this person's all right, and they're going to give you good care, and so you should go and see them. So it is my job now as a medical director to maintain that network of providers and to make sure that anyone who needs care gets it ASAP and from someone that we trust and communicate with. For that reason, Fountain House does a lot of outreach to training programs for residents and medical students, including now with primary care training programs, so that we maintain a network of trusted partners. And we need to make sure that we keep the lines of communication open with all of these outside providers as well. So that, in short, is how some of the nuts and bolts of how we have engineered this Clubhouse community system of care at Fountain House. Next slide. I'm going to hand it over to Kevin Rice now to really dial it down into what are the specific roles within this Clubhouse community system of care, and what is this Rehabilitation Alliance that we keep talking about. Okay, thanks, Kevin.
Thank you, Dr. C, and thank you, Cyrus and Diona from earlier. So in speaking about the roles in this community system of care, we really want to highlight that one of the things that's really important for success in these integrated care strategies is the ability for us to understand what are the the lanes in the area of overlap and handoff that occur amongst the partners that are coordinating and operating together in these circumstances of trying to have mutual care responsibility and coordination and shared decision making when it comes to managing serious mental illness. So we're going to highlight a couple of what we see as the primary roles in participating in these coordination and circumstances. And then I'm also going to hand it off to our colleague and contributor to the training, Dr. Atchis, to speak about how that is positioned in his role, both from the clinical, medical, and also psychiatric side. So if we can go to the next slide, we can start with the side that I have a lot of familiarity with as a former social practitioner, which is the role of the Clubhouse, its membership in the social practitioners and contributing to the integrated care experience of this community system. And as Dr. C really alluded, the Clubhouse really serves as the environment where maybe some of the treatment recommendations or the guidance that gets achieved or provided in other types of settings can be acted out, can be checked upon, can be followed up with. And it's managed not through the sense of oh, this is what your doctor said. It's consistent with the goals that are being presented and navigated within the community that are immediately relevant for the member. So that generates a shared sense of achievement. And this idea of communal tasks that are the consequence of maybe some of those prior treatment guidances, or the self-decision or encouragement that's received in the Clubhouse itself around the work order day, where there's a peer support, there's a community of moving towards and maybe counteracting histories where there wasn't maybe certain experiences of achievement or accomplishment that could be pointed to. The other thing that is really occurring for the members and social practitioners and their role in this community system of care is that they're working together and developing a shared social history through the completion of these tasks that it's necessary to develop the Clubhouse. And that's one of the really key things that we're going to highlight and circle back to in the Rehabilitation Alliance is this idea of a shared social history contributing to the interactions and decision-making that's happening in clinical settings. And one of the main contributions that social practitioners are able to do is they're able to serve in this hybrid role of both being a assessor, care coordinator, and someone that's there to participate wholly with that person as an individual and as a person and not as a patient, and to develop shared experiences, aspirations, and accomplishments together that are completely maybe even detached from any type of care or health consideration, but they're just about everyday social considerations for the member themselves. And that develops into a shared social history that is able to then be transported or taken with into those other clinical decision-making settings, either on behalf of the social practitioner or from the member themselves, now that they're able to lean on or reference to the things that they're working on either in their community or the things that they're aspirationally seeking to then inform the types of interactions that they want to have with care providers. So that's where this social practitioner is trying to have that focus of intentional engagement and the promotion of individual goals, either can be something that is advocated for on behalf by the social practitioner, or can be encouraged for the member to do for themselves as well, by also not just kind of having lip service for it, but by having real experiences and a shared social history of accomplishments that are being guided towards a certain trajectory that's being led by the member themselves. And this can kind of lead to, the kind of advocacy and the experiences with either the practitioner coming into the offices of a clinical consultation themselves, or for the member to advocate for themselves based upon the experiences and goals that they're working on within the clubhouse. Next slide, please. Another kind of participant role in this, we also really want to acknowledge, is the role of family members in these kind of community systems of care. So not only, sometimes those things get fulfilled by social practitioners in the community, but oftentimes many people have a real kind of support system that is robust in amongst their family. And we also have seen and done some studies about how family members interact with the clubhouse itself and how that helps them further facilitate care decision making that happens in other clinical settings. And there's this real idea of caregiver burden that also gets really impacted by clubhouse interactions with the member and the family as a whole. And also then how that is also able to be alleviated in other kind of clinical settings where, maybe there's not this ability to so readily translate what are the kind of social goals that either the person who's in my family that's managing mental illness, or the things that I want for them, or the management that I'm trying to negotiate along with them. How does that, inform the kind of decision making that might happen in a doctor's office or something of the sort? But family members play a critical role, and they seem to really benefit also from the components of the clubhouse experience that the member is contributing to, as well as the goals that they're working on within that community. But that's from the side of the membership, the social practitioner, and the family. To kind of speak about a little bit up from the side of what the roles and the kind of this continuum of care from the psychiatric and the medical side, I'm going to hand it over to Dr. Atchis to speak on the next two slides to how he kind of sees the kind of supports, services, and areas of fulfillment that the providers can play in these systems of care. Dr. Atchis.
Well, thank you very much, Kevin, and thank you, Dr. C, and all the previous speakers. You really set the stage very, very well for the role that I think psychiatric and primary care practitioners play in the role, in the lives of members of clubhouses, and really how clubhouse membership can enhance, ideally really enhance the interaction that physicians have with clubhouse members. So, traditionally the role of the physician is to think about, okay, let's assess how somebody's doing, come to some sort of a diagnosis that we can work from. Often these diagnoses are works in progress. They're provisional at first, and they develop over time and may change over time. So having consistent input from the member, from people in the clubhouse, really helps with that assessment and diagnostic portion of what a doctor is supposed to do. And then we often prescribe lots of different things. We might say, it'd be great for you to go for a walk. It'd be great for you to, if we can facilitate some sort of social interactions or clubhouse or other things, we'd love to recommend those things. And also physicians are always and often managing medications and those recommendations. So for us to get input in a shared decision-making process, as Dr. C talked about how a medication treatment might be affecting somebody, is really, really critical. It's always a partnership. We are always looking for more information. How can we do this better? How is this impacting your life? Are there things that we can work out that would allow you to achieve your recovery goals? That's really what we're after, not just symptom reduction. So again, Clubhouse can play a really critical role in this. Certainly, as has been mentioned, there's the opportunity to catch things. So if somebody's not doing well or having trouble, I think as mentioned, falling asleep or having difficulty staying awake while at the Clubhouse, that is information that can then hopefully be translated and shared with a doctor so that changes can be made, and somebody's experience and their ability to manage some of those symptoms can actually be improved more quickly. So that is, I think, absolutely critical. And of course, if there's a crisis or something like that comes up, again, that information is shared quickly. I wanted to echo what Dr. C said as well, that from a psychiatrist perspective, I feel so much more comfortable taking, making medication changes, reductions, taking appropriate risks to try to mitigate side effects from medications because of the extra support that comes with Clubhouse and that safety net, that community that's surrounding the people that we're working with. So I can't say enough about that. I do think that psychiatrists and other mental health clinicians, we have a role as advocates and also consultants in a patient's recovery. And so we should be sharing what resources are available in the community. We should be aligning the recommendation for resources with an individual's life goals. So that's really important for us to try to elicit, what do you want to do? Are you going back to school? Are you going to work? Are you, looking for a place to live? What are your relationships like? And if we can find a way to partner in those things, then the medications and everything else kind of falls into place as we're working together. All right, next slide, please. So similarly with the role with primary care, so I'm a psychiatrist by training, but I really depend on my colleagues in primary care to help address and manage so many of these things that Dr. C talked about in terms of diabetes, cardiovascular disease, cancers, maybe cigarette smoking or other things that might impact long-term health. We really need to work together to make sure we're all on the same page. And I kind of see it as really a collaboration. We've got the individual we're trying to serve, and then the psychiatrist in one corner here, and maybe the primary care in another. And there's got to be relationships between all of those. And Clubhouse can really help facilitate all of those connections between primary care, psychiatry, and the individual we're serving. And I think that is really, really critical, that communication be good and it be clear, so that we're all on the same page and pulling in the same direction. It's mentioned here that physical health screenings and assessments might be facilitated by a Clubhouse, and I think that's terrific. If somebody comes in and says, "I need a doctor," if somebody from the Clubhouse can say, "Hey, let's get you. We've got a really good clinic down the road. There's people there that we trust. Let's get you connected so you have somebody when you get sick. If you get a cold or your feet are bothering you and anything like that. If we can have a doctor, somebody that you can go to, somebody that you can trust, that is really, really essential. So integrating those roles, I think, really can lead to improved health outcomes. That's something that has been shown in studies, and we really want to try to help facilitate that. And I think the Clubhouse provides such a wonderful environment for helping people better their health in context of reaching their goals for their lives. Okay, and with that, I will turn it back over, and thank you again.
Okay, thank you, Dr. Atchis. So with these components, of community supports, the member themselves, medical and psychiatric, with that community system of care, we really feel like then what is happening is not just a convergence of services being present and coordinating with one another, but that when you have kind of the Clubhouse and the community components contributing amongst these other partners, you are going to generate something that we call the Rehabilitation Alliance. And it's something that's more than just kind of coordination of services operating not only just in tandem, but that there's something that is moving through the interactions that is really deconstructing either the power dynamics that are maybe traditionally operant in those settings, but also you're interjecting the kind of, like I mentioned before, the shared social history that is being present and have relevance and given priority in the decision-making that's happening amongst those other care settings. So the community system of care may have all these components, but then you also need to have this Rehabilitation Alliance kind of motif principle that is about kind of this trust brokerage, the deconstruction of power dynamics, and the relevance of the totality of the person's social experiences that are being acted out either in a community supportive rehabilitative setting that can then be relevant and have translations into those other kind of care settings, so that it's not, as we mentioned before in the module 1, the community system of care needs to have kind of community-based supports as a component in addition to psychiatric and medical. But then also, as we mentioned in module 2, what does that look like? What is the community contribution beyond just maybe some of those, or are they helping people get connected to housing and employment? It's also this kind of experience of social practice, of relationships, of hope and aspiration and encouragement that is also operating, that provides the engine for the Rehabilitation Alliance. So there's the architecture, and then there's the engine, and then there's the fluid that kind of goes through it. And that for us is that community system of care engine. And then the Rehabilitation Alliance is kind of, the fuel that really drives the relationships meaningfully within it. Can we go to the next slide? So in the Rehabilitation Alliance, we've kind of really defined it as something that leverages social histories to inform care decision-making, focusing on strength and life goals, acknowledging problems and clinical needs while recognizing the non-linear nature of recovery as it occurs in individual and communal context. So once again, it's about having this not only just continuum of care, but continuum of experience, goals, and an understanding of where the advocacy maybe leads to treatment decision making, but then also leads to a place where we can have confidence, where that treatment guidance can be acted out in a supportive way that's consistent with the members' own goals and the things that they are advocating for, either from that kind of circle of, well, I'm finding out what it is that I want to work on, what I want to be, what I want to do in the Clubhouse community. I'm able to represent that in my interactions with my clinicians, and then I'm taking the guidance that I'm getting from those clinicians and bringing them back to that Clubhouse setting to help kind of support it, and then track and communicate to those people in my community how that can be reinforced. And that cyclical nature of kind of self-advocacy, efficacy, and being able to move into those decisions, but then also having a place where they can be acted out, is really at the core of this Rehabilitative Alliance notion. And social practice really helps facilitate the kind of facilitation of the member at the center of that entire process. And that can be achieved through the members' interactions within the Clubhouse community that then it becomes relevant in those other kind of care settings. So it's these network of relationships. It's not just kind of different points that have thread going between them, but there's an energy, there's a coordination of the totality of the person and their goals that is being prioritized within these. And there's a real foundation of mutual trust and respect, because things are being informed not just of like, oh, I'm making a care decision, like Dr. C mentioned about how am I mitigating diabetic risk, or how am I mitigating maybe voices, but it's like, how am I supporting this person to be able to maybe go into work the next day, or to be able to work on the types of things that they want to be able to do, or to have the relationships that they want. That is a trust brokering experience that is seeing them as at where the person is and what their desires are, and not just merely what those kind of outcomes or process metrics might be from a kind of clinical or service provider position. And it really is about stabilizing, restoring, and enhancing the ability for the person to function consistent with their goals and how we can be of service to that. And so can we go to the next slide? And wanting to emphasize once again that in being of service to that is that facilitation of trust and that building of trust, and how when we have that social history that's able to either be represented by the practitioner themselves or to be acted out by the member and then translated to the types of interactions they want to have with their clinical providers, that there's a whole new kind of trust brokerage and dynamic that's able to kind of supersede maybe previous experiences where there wasn't that trust, or maybe also expectations of what can I be expecting from this interaction? What is this person actually wanting for me and on my behalf? And is it coordinated? Is it vetted? Is it going to be consistent with the other things I'm working on in the other settings of my recovery journey? Whether that be the Clubhouse, my own kind of job, my community, the doctor's office, and so on and so forth. But the real emphasis here about this Rehabilitation Alliance is this centralization of trust and the facilitation of it through Clubhouse experiences, advocacy, and encouragement and engagement with the community and relationship development. And to kind of speak about how that facilitation of trust really kind of leads into the types of interactions and recovery experiences for members, is I'm going to hand it over to my colleague Craig Baer to speak about his experience within these dynamics and how he sees them really benefiting and contributing to the benefit of the membership themselves. So Craig, I'm going to hand it over to you.
Thank you, Kevin. I wanted to emphasize the importance of trust and integrated care here. It's very important that the community psychiatrist generally believes and assists the members in their recovery. He's not just there to dispense medication. But sometimes, and I think Dr. Aquila, Dr. C, Dr. Atchis are very good examples of people who have won the trust of their patients because they believe in recovery and they believe in assisting in the recovery. But sometimes the patients don't automatically trust the doctor. You know, sometimes they don't want to talk with him. They don't want to share with her. Sometimes you feel that the psychiatrist is one step away from hospitalizing you, and therefore you could have a serious problem of trust in the very beginning. And what the role of the Clubhouse here is to sort of reinstill some of the trust. The patient and the patient or the psychiatrist and the member are aided by the Clubhouse community in the recovery process for helping to restore some of that trust. Through the members' work in the Clubhouse can discover the members' strengths, the Clubhouse can discover the members' issues, and these are things the psychiatrist needs to know. At Fountain House, sometimes we even have the social practitioners or the social workers come into the session with the psychiatrist. And that's very important because the social practitioner can advocate for both the psychiatrist and the member in this interaction, and it helps rebuild the trust, the essential trust that the psychiatrist needs. The reason the Clubhouse is able to do this is because the Clubhouse spends 8 hours a day, 5 days a week with the patient. So so they can tell when the member is doing well or doing poorly. This Clubhouse can advocate for the member, and therefore, but at the same time, since the member is in charge of this entire process, the member is there. Nothing is said behind his back or her back. The member is there with the psychiatrist and the social practitioner, or with anybody else in the Clubhouse who's speaking to the psychiatrist. And so nothing is said behind his or her back. And as a result, the member can challenge assessments as they're made. We can disagree. We can correct the psychiatrist and the Clubhouse if necessary. All of this talk of trust is very important in the patient's recovery and growth. The member must trust the psychiatrist. The psychiatrist must trust the member. The Clubhouse must trust the member, and the member must trust the Clubhouse. And all of this, of course, enhances the member's recovery and growth when everything is working together. The member starts to trust himself even more, because and that's vital too. If you're not encouraged to trust yourself by your clinical or Clubhouse setting, you're in big trouble. You have to have some faith in yourself, and that's what the Clubhouse does. It helps reinstill faith. I think the most dramatic example of what happened to me in the Clubhouse is when I did a colleague training in London, United Kingdom. I was sent there by the Clubhouse to represent Fountain House and do a colleague training. I flew there independently into London. I worked with a staff member, a Clubhouse staff member in London, and representing Fountain House and doing a Clubhouse training. We learned about how to run a Clubhouse, and we came home with suggestions for our Clubhouse on how to improve our Clubhouse. But I had a therapist who was unconnected with the Clubhouse. After I came home from this trip, I spoke to her about this experience, and she said to me immediately, you know, the Clubhouse really trusts you to send you overseas and represent it like that. And it occurred to me that, you know, she was absolutely right, that there was a certain trust element there that helped my recovery and growth. Fountain House trusted me to go overseas and represent the Clubhouse, even though I was a mere member as opposed to being an administrator or a PR person or something like that. So I think this is very important, that to the patient's recovery, that trust is instilled all over the place. And I also wanted to mention that my family trusts me a hell of a lot more when they know about the work I've done at the Clubhouse. So that's basically my particular point of view. Thank you.
Thank you so much, Craig. I think it's really powerful what Craig just talked about, you know, that the amount of trust that's available in the Clubhouse because of this Rehabilitation Alliance. You know, I felt like the first time I met Craig, he trusted me because Dr. Aquila had, chosen me to come to the Clubhouse, and that that in some way the whole Clubhouse was able to welcome me because I had been vetted by members of the Clubhouse and staff. In the same way, I trust Craig implicitly. He's taught me a lot of what I know about Clubhouse. And when Craig, says anything, I know that it's not just him saying it, but he has been informed by all of the people that he meets in the Clubhouse and the long history he has with the Clubhouse and everything he's learned from it. And so that sort of like collective intelligence, that network of trust is amazing, I think, in terms of the power of Clubhouse to change care dynamics. If we can go to the next slide, I'll bring this presentation to a conclusion and concluding all 3 webinars. I hope that we've demonstrated to everyone the importance of community-based supports, of entities outside of psychiatry and primary care and specialty care, that these kinds of supports are key to successful integrated care that serves a person really holistically, that serves the whole person. And that we've explained to you how Clubhouses are an example of a really well-designed, intentional therapeutic community that promotes recovery for people with severe mental disorders. And today, I think, I hope that you've learned from Kevin and Craig and others that the Rehabilitation Alliance that's nurtured by these partnerships between Clubhouses and psychiatric providers supports people's engagement, their ability to trust, their ability to understand and be understood, their ability to make shared decisions with the Clubhouse and with their providers, and in the end, optimal treatment that provides for a long, healthy, high quality life. And so that brings our presentation to a close, and I'm going to hand the time back over to IVCI and to Kevin Rice, who will moderate our Q&A. Thanks, everyone.
Thank you, Dr. C. For those that have questions they would like to ask, please submit your questions in the Q&A pane, the icon of which can be located on the bottom of your Zoom window. Kevin will moderate today's Q&A session. Kevin, the first question we have today is, what is the panel's view on it's okay to not be okay? What are the pros and cons?
I'm going to hand that one over to Cyrus to maybe start with, and then I think some others will probably jump in as well.
Sure, that's a very interesting question. I think off the top of my head, I would say that in a certain sense, if you're a member who is not feeling well, that's understandable. It's not something that Fountain House or the Clubhouse community is going to hold against you. We have the relationships that we have built over time, going back to this whole issue of trust, where if you're not doing too well, you have a place that you can go to. And I'll give a quick example from my own history. Is I wasn't doing so well one day, and I got to my job and I told my supervisor that I wasn't doing well at all. She offered to take me to the hospital if I needed that. And that made me feel very supported. In the meantime, I had called my psychiatrist and was waiting to hear back from him. Then I called my worker from Fountain House and told her what was going on. And again, it's not very often that you have employers that are willing to take you to the hospital if there's some sort of emergency situation. It's very unusual for a social worker outside of the Clubhouse community to come to your job and pick you up and go to the pharmacy and get the medication you need to help alleviate the symptoms. Now, I think others on this panel will definitely add to that, but that's how I want to start us off. That if you're not doing okay, let's work with that. And let's see what we can do to help you get to where you need to be. I don't know, Kevin, did we want to turn it? I don't know if Craig had any thoughts on this, or Dr. Atchis or Dr. Aquila or Dr. C.
I do have a brief thought. I'm taking it from another angle, the question of whether it's okay to not be okay. I think the Clubhouse, for the most part, doesn't believe it's okay not to be okay. I mean, you have your bad days, of course, but what the Clubhouse doesn't want you to do is give up on your recovery. The Clubhouse doesn't want to give up on your recovery. And you don't want to find yourself, as so many people unconnected with the Clubhouse do, staying in your apartment all day long, watching TV or listening to the radio, or drinking or drugging or stuff like that. You don't want demoralization to set in and for you to give up on yourself and your recovery. So I think the Clubhouse is not really interested in telling you that you're okay to be not okay.
Yeah, I would maybe just add, the way that I interpret this is it's a come as you are kind of invitation, that whether you are feeling well or not feeling so well, we want to see you, come on in, you're welcome. And I think that's really important. And then come in, you're welcome. And if you're not doing well, how can we support you to feel better? And how can we support your recovery so that you don't stay in that place where you're not feeling so well? So that's kind of how I interpret that phrase, if that's helpful.
Yeah, I'm going to echo that. And I also want to say that It's Okay to Not Be Okay is also the title of my one of my favorite Korean dramas that actually deals with mental health issues, and I'd recommend it to everyone. It's on Netflix. But I would say, the question is rich because it really brings up, like, what does it mean to be okay or not okay? How are we judging other people when we say they're okay or not okay? And again, are we really judging that based on people's recovery principles? There are people probably at Fountain House who respond to internal stimuli, who hear voices, and they're able to do their work. They're able to have friendships. They function as part of the community. And so if we're talking about voices as being not okay, then yeah, it's okay. It's okay to hear voices and live your life, and you don't necessarily have to take medication if the voices are not bothering you, right? So in that way, it's perfectly okay. But when someone subjectively feels that they're not doing okay, the Clubhouse is here for them, and it's not okay to leave that person in that state. Obviously, it's all hands on deck at that point.
Can we go to the next question?
Certainly. We did have a question that came in, and I also had comments as well. Two comments that struck me in conversation between Cyrus and Diona. Number one was Cyrus. People with serious mental illness want the same things as others. They just need a bit of help. And number two with Diona, the things that she said that she needed can be captured by Tom Inzel's 3 Ps: people, place, and purpose. These are 3 things that everybody needs. So how can we measure that, track that, and improve that as a society?
I might take a first stab at this as a researcher on this topic, and then I can maybe hand it off to some of my colleagues. I think one of the main things about measuring and tracking this is providing a space where the 3 Ps can be actualized, so that you can create an environment where these things can be observed and the things can actually occur within, right? And so you need these settings that are focused on providing these solutions so that you can then see the efficacy of how they're having that type of impact. Right now, as we made an argument for in module 1, these settings usually operate as an island onto themselves, and we don't get to see how they necessarily impact or have a downstream or an integrated care contribution, because they're usually left out of the equation. And so by further facilitating the kind of role of Clubhouses and other community support services and centralizing them within these kind of care networks, we'll have a better way of being able to see what those impacts are, about how experiences and maybe exposure to these settings are having impacts in other kind of settings of interest, such as hospitals or clinics, or diabetes remission and things like that. And so we can get to explore it by having these settings and building them out as places that are have research readiness and components that can be measured and studied, as well as a a generalizable theory of change of what's actually happening in them, which we talked about in module 2, which is social practice and what the strategies of interaction are. I'm curious if other people's have responses to this comment.
Well, regarding people, place, and purpose, I think the Clubhouse is an obvious place where that's addressed. I mean, isolation can be deadly, and the Clubhouse, the first thing the Clubhouse provides is people, from all walks of life coming to your aid to make sure that you're okay mentally, socially, professionally. So the Clubhouse is the place, at least a transitional place. It could be the workplace. The workplace is very essential to a lot of people's lives, but sometimes you're not in the position where you can work or you want to work. So the Clubhouse serves as a place where you can go and be yourself and set goals and initiate your recovery. And purpose, the Clubhouse provides purpose as well. So if you're not sure what your goals are, whether you want to go on education or whether you want to have a career, one of the things you can do is at the very least to serve the Clubhouse. You're serving the recovery, your own recovery, and the recovery of other members, and that's vital, I think, for a person to have some sort of idea of what they're going to do with their day, what they're going to do with their lives, and that too is at the very least a transitional place of purpose. So that's my take on the subject.
I guess as the old guy here and somebody with history, I just wanted to bring up a name that I haven't heard mentioned yet. And it's from a paper from, I guess you can't see it with my background, but it's from a paper from 1964, edited by John Beard, where he clearly underscores and defines the notion of a place with a purpose. So I did want to give John credit. We haven't heard his name, and I guess just my old wanting to go back in time. So.
Can we have the next question or comment, please?
Thank you. What is possible when the medical providers partner with Clubhouses?
I'm going to hand that over to Dr. Atches and then hear from other people in their responses.
Well, I mean, like we talked about earlier, I mean, I think that partnership is really critical, and I think it just leads to potentially better outcomes. You have the ability, as we talked about, to use medications maybe at lower doses. You have the ability to bring in so many other facets of recovery that can be beneficial, that I think the chance for people to live their most fulfilled life happens when those partnerships are present. So I'll leave it there and see if others have other comments.
I
would simply add, oh, sorry, Ralph.
No, go ahead.
I would simply add that, the Clubhouse usually doesn't have a direct relationship with medical providers, but I know in my sessions with my psychiatrist at Fountain House, I am asked medical questions to make sure that, that I'm not just tending in my head, but my body as well. And that's vital because one's mental health doesn't have much meaning if your physical health is deteriorating. And obviously you're going to, if a medical issue arises in your conversation with your psychiatrist, well, then you'll be referred to a medical provider inevitably. And that's how the system works at Fountain House.
Yeah, I was just going to add, we were talking before we started the presentation today, that it's a luxury to be a psychiatrist affiliated with a Clubhouse. And it's just a great experience because you've got all the support, all these resources, and it's really quite wonderful.
I think working in a very complex healthcare system where provider longevity in any one institution is very limited, that's been a struggle for, I think, the Clubhouse to really find primary care partners in the community that are going to last and that really serve our members. But I think that's why Dr. Aquila really created the partnership with Ryan Center too, because that's a group of really strong docs who are committed to serving people with mental illnesses or anyone who has additional needs. And when we nurture relationships like that, I think everybody wins. The medical providers in their mission to serve people, and the Clubhouse in their mission to ensure that every member gets good preventive and acute care as well.
Okay, let's go to the next question, please.
Thank you. Would partnering with social or community organizations and interventions reduce overall healthcare costs?
There are a couple studies that do indicate that there is a financial healthcare cost impact. That is, there's a 2017 study conducted with the NYU that looked at kind of Medicaid expenses and healthcare costs, and that for members of Clubhouse. Now, there hasn't been a study that looks quite yet. We hope to do one that looks at when you have people that are participating in all kind of, the components of what we would consider a complete system of care kind of experience, and to be able to measure that and identify people that are maybe either associated with a particular clinical partnership, and a Clubhouse relationship is one that I think is active, and we're kind of looking into further upon. But there has been analyses and research done about the impact of Clubhouse on the reduction of healthcare costs. We can probably go to the next question.
Thank you. The next question is, what is the process for accessing the PIC curriculum and related toolkit implementation materials? Is Fountain House interested in partnering with organizations around the globe to test the model in other contexts?
I'll hand that one over to Dr. C as the medical director to speak about how those kind of partnerships are developing out. And then I'm sure others also have something to contribute to.
Sure. I mean, the shorter answer is yes. We would love to partner with anyone who's interested in participating in testing and disseminating this model. What we really want is to both promote Clubhouse as a solution to issues of integrated care. In addition to, last night I presented on Clubhouse as a solution to homelessness as well. And we want that to be spread as widely as possible. And we want providers to really be able to trust that Clubhouse will be helpful to them. So we have just started partnering with SUNY Downstate here in New York City to promote and test this curriculum. Dr. Atchis has also piloted this curriculum in Michigan. And anyone who wants to, please just get in touch. We would love to talk more about how we can implement and test this curriculum where you are.
So I would just add on the sly, Craig and I presented this to the UPenn residents, and it was very well accepted. And I did want to say, otherwise I'd be remiss, I wanted to thank Dr. Pernicha and her gang at Wayne State for having helped put this whole curriculum together. And I really feel strongly that this is going to be a major contribution to the field in educating mental health professionals when it comes to the notion of recovery.
Thank you. Next question.
The next question is, Clubhouse is new to our area and clinicians are not knowledgeable about the model and are reluctant to make referrals. There seems to be an odd ideas about it, and I don't know how to break through the resistance. Any suggestions?
I might pass that one to Dr. Aquila to maybe talk about, and then I'm sure others have some contributions on that as well.
Well, I would say the best thing is to reach out to the clinicians and give them an invitation and have them come over and sit down and see the model. I mean, we've done that in the past. We've gone to different cities, and we have reached out and met with the folks who are providing the services. That would be my 2 cents. But also, I know it's an ongoing thing. I know, Eric, you've been doing this, and Gina, you've been doing this. So, and we all have been doing this in various venues. So I think the important thing is reach out
Yeah, I mean, I think there's nothing like a tour of the clubhouse to really get an appreciation for the impact that it has for folks. And it was something I experienced as a resident physician in training in Boston. And then when I came to Michigan, I was able to see and tour our clubhouse here. And then I even was in New York City a couple of years ago, pre-pandemic, and Dr. Aquila invited me over to tour Fountain House. So seeing the place, seeing how it works, seeing the people, meeting the people, there's nothing more powerful than that, in my opinion.
Yeah, I would also add that member stories are another component to this, as well as the tours, because when you hear, like Diona's story earlier today, when you hear the impact of the program that she was in before, where she was not treated with the respect and dignity I think she should have been treated, and coming to Fountain House, how her life has changed so dramatically that she's planning for the future. So I think member testimonials, I mean, Fountain House has a YouTube channel. There's tons of videos there that you can look at to hear member stories and about other work that we're actually doing in the community. So that's how I would respond to this question.
I would also volunteer these people on this panel. If you ever want to reach out to any of us, one of the goals of this curriculum is to serve as a platform to start that conversation with partners from a basis of kind of really thoughtful consideration, looking at certain evidence-based practices, and also looking at the kind of considerations of where the advocacy for where the field needs to head around integrated care strategies, and the considerations of the kind of the unmet needs of psychosocial supports, and then how those can be readily integrated. I mean, I feel, if you are present as a clubhouse in your community as a clinician, you already kind of maybe won the lottery because you have that resource adjacent to you. There's a lot of places that don't have sometimes psychosocial supports around there. And so we hope to have this curriculum serve as that platform for the conversation, not to just be kind of you testimonially kind of advocating for yourself, but to be able to reference material. And also ultimately what I'm saying is also to have a team that can maybe help support you in those connections and conversations.
I agree with Cyrus that member testimony is essential. Member stories give you a great picture of the clubhouse. I can also tell stories of people unconnected with the clubhouse who are not doing quite well. They are being treated by the clinical community without much success. And so my challenge is, show me something better than the clubhouse, and perhaps I'm willing to hear other modes of treatment.
Yeah, if I can relate a quick story. I had hosted about 25 social work students and their professors from Japan a number of years ago. They stayed at our guest house down the street. Now, none of them except the professors spoke English. So I arranged for tours of Fountain House, and then I had hosted a dinner about 2 nights afterwards. And I went around the room and I asked them through translation to talk about what they saw and observed. And every single one of those students, even though there was a language and cultural barrier, got the model. They understood what was happening just by observation of what was going on in the units, how we break down the work in the clubhouse itself. And I was blown away by the fact that they got it and they understood it. And we're looking for ways to replicate the model, particularly in low to middle income countries. I mean, there are programs, there's a clubhouse in Kolkata, India, there's Fountain House, Pakistan, and that's in 3 cities, including Lahore and Sargodha. I don't remember the third one off the top of my head. In Eastern Europe, in South America, in East and Southeast Asia, where there's a definite need. So it's so easily translatable and understandable to people, even if they haven't had the formal training or there's a language or culture barrier. I think that that's the beauty of the model, is that it can be placed in any community and you adapt it to the needs of your community overall.
Thank you. Next question.
Certainly. I would like to pause a moment just to give some feedback that we received on Diona's story that she shared with everyone. The comments were flooding in when she was speaking about how powerful her story was. And congrats to her on all that you have accomplished and all that you are planning and will accomplish in your future. And thank you for sharing your journey with us. It's so inspirational and really seems to reflect what is special about the Clubhouse model. So I definitely wanted to outline those and give Diona a round of applause for her powerful story and sharing with everyone today. So our final question for today, and we'll close out, is what are the most important changes in mental health support for people with serious mental illness that you would like to bring with the PIC curriculum?
I think maybe Dr. C, would you like to start with this one? And then I'm sure a lot of people have some contributions for this question.
Sure. I hope we've really emphasized today that the biggest change that we hope is that people will use community support to build community around people to support their recovery and recovery on people's own terms, led by them. That's what I really hope.
I'm also really hopeful that there's through this curriculum, there's a strategy for how to do that too. There's a sense of what is actually occurring within these settings, how they operationally contribute to the recovery journey of individuals, rather than just saying community and leaving it just kind of at that. Module 2 kind of got to really dive into what that looks like, and also Module 3 then is a lot of our contributors here today highlighted is how that then informs the everyday decision making that happens in integrated care settings. So rather than just kind of presenting an advocacy position, we hope to kind of through the PIC curriculum present a blueprint for the strategy for implementing and understanding how these things work in action, rather than just kind of, a clarion call, which was kind of our response, is that we saw a lot of people saying integrated care needs community, but we didn't see a whole lot of materials and resources out there that said how that works and what happens when that is present. And that's what we really hope to be adding to the conversation through the PIC.
I would actually just slightly disagree with you, Kevin.
Okay.
I'm not convinced that there's a lot of integrated care models out there that understand the notion of community. And what I think the PIC modules does is it really highlights that and underscores it in a very eloquent way. And I'm hoping that that's the message that we're able to get out there. Certainly just beyond the rah-rah of yes, community and integrated care, but I think the Clubhouse model and the way it's depicted in the modules will educate mental health professionals, and I hope society at large, how the two need to be mutually included.
Agreed. Anyone else about their hopes and aspirations for the curriculum? It's a good question to end on, so that's why I'm giving others the opportunity. Craig?
Well, I think all of this trust conversation and indirectly helps end stigma for people with mental illness. If you trust them, if you have faith in their judgment and their ability to recover, we're all in a better position in dealing with society.
Great. Okay. I guess we'll hand it back over to Dr. C to close us out, or is it back to IBCI?
Thank you, Kevin. You are correct. Dr. C, you can close us out today.
I'm just going to close by thanking the panel, this esteemed group that has worked on this training, and for all of the people who have attended. Thanks for being with us. We really hope that you have gotten something that will help you to promote recovery among people with severe mental illness today. Thanks so much.
Thank you all for joining today. If we have not answered your question, please feel free to send an email to pic@fountainhouse.org. That's PIC@fountainhouse.org. An upload of the webinar will be made available on fountainhouse.org in the coming days. Thank you again for joining, and have a wonderful day.